Welcome all to attend this academic meetings for the Asian Society for Emergency Medicine. I'm Dr. Axel, the past president of the ASEM. Welcome all of you to attend this meeting first. And today, as usual, we will have the three parts in this presentations. First of all, we will have a case presentation, and secondly, followed by guest talk, and finally, we have OSCE presentations. Without further delay, I would like to introduce the first speakers, Dr. Andrew Ottervalens. He is the consultant emergency physician from the Bandung, West Java, Indonesia. He graduated as a doctor from Maranatha Christian University in 2003, and later on, he continues his training in emergency medicine in the Brawijaya University and graduated in 2016. Well, currently, he is the head of the emergency departments of the Emmanuel Hospitals, Bandung, West Java, and he is also the clinical lecturer of the Maranatha Christian University. And also he is interested in critical care emergency and emergency ultrasound. So I would like to pass the mic to him. But before that, I'll make sure that if their speakers is ongoing to giving the talk, please keep yourself mute. Otherwise, there will be disturbance to the speakers. Thank you very much.
Thank you, Prof. It's a pleasure to be here. I'd like to share my screen. Everyone can see my screen? Okay, thank you. Okay, let's get started here. So I'd like to thank you, Doc. I would like to share my case about traumatic cardiac tamponade. As we know, cardiac tamponade or pericardial tamponade is a life-threatening condition with characteristic by accumulation of fluid in pericardial space. And pericardial tamponade must be enhanced or found first based on physical examination, not from ancillary examination. Ancillary is just to confirm our diagnosis. Let's find out with my patient. This is my patient, 43 years old. He came to my ED after being stabbed with a screwdriver by a fellow driver. He complained about pain in the area. In physical examination, airway is clear. She can talk clearly. She can complain pain, and the chest or thorax is symmetrical, bilateral. Respiration rate about 33 times per minute. Out and clammy, acral, diabaretic, and pulse rate 128 pulse per minute. BP 80/40. Oxygen saturation about 91%. Disease is complex mentis. Pain score is 10/10. General appearance, patient is restless in pain. Conjunctiva is normal. JPP or jugular venous is distended, like this picture you can see. And the chest is, there is a small 2 centimeter wide of stab wound in intercostal 5 linear shape. Both lung is clear, vesicular breath sound, and muffled heart sound. Abdomen is unremarkable, flat, no visible injury, no tenderness, no guarding, no mumble movement. Extremities is cold, clammy with ready pulse. By this physical examination, we can conclude that this patient has a shock. What kind of shock? We can see only one shock with jugular vein distended. That is obstructive shock or mechanical shock. So we can choose between two about mechanical shock. One, tension pneumothorax, pneumothorax, or tamponade cardiac. In this patient, lung is clear, symmetrical, bilateral is clear. Lung, vesicular, symmetrical, both thorax is clear. So pneumothorax can roll out. And another, we can conclude this patient has a cardiac tamponade. Cardiac tamponade, we can see this patient has a classic presentation of bacteria. We can see by the jugular vein distended, muffled heart sound, and the patient has hypotension. This is very, very classic. And another feature of clinic feature, the patient has a tachypnea and tachycardia. So this is the one. And assessment, professional diagnosis is obstetric shock due to suspect cardiac tamponade. For management, first I give him 10 liter per minute oxygen, renal lactate 1 liter over 1 hour, followed by 500 cc over 6 hours, human tetanus immunoglobulin, painkiller petidine, antibiotic prophylactic antibiotic ceftriaxone 1 gram, and I perform trauma protocol EVAS. EVAS protocol unremarkable unless in one view. There is subsequent view or cardiac view. First, I will scan the lung. The lung is clear. We can see in fast, there's the lung, sorry. Normal lung is, sorry. We can see the lung, both lung is same. The normal lung is, there is a A-line profile, there is a sliding pleural line, and F profile. This is a kind of feature of normal lung. What about in Morrison? Morrison or hepatorenal is normal. We cannot see the free fluid, and we can see also the solid organ of hepat is homogeneous. So I think the hepat is okay. There is no free fluid. And left side, we can see the splenorenal, also normal. There is no free fluid. We can see also contour echo texture in spleen is homogeneous, is normal for spleen. And we can see suprapubic retrovesica also normal. There is no free fluid in retrovesica. But in subsequent or first chamber subsequent, we can see the duct or free fluid in pericard space. I use probe. We can use to probe sector or phase array or use group or abdomen probe. We can see in my ultrasound there is a free fluid in pericard cavity. There is a space between or gap between pericard parietal with myocard. There is about 2 centimeters. What about pericard tamponade? Pericard tamponade we can see in this patient by this patient has a diastolic collapse in diastolic at the right atrium and right atrium and right ventricle. It makes a fixed ventricular volume, so the patient has to backward the blood to jugular vein. So the patient has a jugular distended. This also make left ventricular filling is reduced. It makes the patient has a hypotension and has a muffled heart sound because the heart is surrounding by the fluid. You can see the patient has also in this view, we can see around the cardiac and pericard. We can also the left side of lobus, liver lobus, and also see the stomach full or empty. This is important to when I perform a pericardiocentesis. To approach pericardiocentesis, we have 3 choices: parasternal approach, apical approach or subsequent approach. For apical approach, I use a linear probe to see the effusive pericarp. We can see the effusive pericarp in apex area that is too tiny, too small. So this is not the best choice to take a pericardiocentesis because it's under a half centimeter. So I choose another approach. The best approach for this trauma or acute pericardiocentesis, tamponade pericard is from subsequent approach because gravitation of fluid. Yeah, this is the benefit of ultrasound. You can estimate the distance between the skin and the how many distance between the skin and pericarp. It's about 5 to 4 centimeters. So I use a needle. I only use needle for 60G to pericardiocentesis. We can also use a spinal needle or a CPC needle, but in this patient, I only use a needle 60G and spread 10 cc. This patient, I'll withdraw about 80 cc, and the patient is getting better. After removal, about 80 cc blood in pericarp, vital sign of patient is getting better. We can see in respiration rate is decreased about 20 times per minute. Acral is getting warm, dry, diaphoretic is disappeared. BP increase 110 and 70 over 70. Pulse rate about 90 pulse per minute, bonding pulse. Oxygen saturation increase 99%. GGS is compost mentis. Pain score 1 to 10. This patient is getting better. So monitoring after we perform the pericardiocentesis. This is the one we compare before and after before pericardiocentesis. This is before. We can see the after. Sorry. Nah, you can see the distance. You can see the distance or difference between the left side and the right, the before and after. You can see the pericarp effusion. In the first one, you can see the distance between pericarp and myocard is about 2 centimeters in this, and after is less under 1 centimeter, and the pumping or diastolic right ventricle is getting better. So this is the make a patient is getting better. So also in ultrasound, we can also find the complication after we perform pericardiocentesis. Like pneumothorax, we can see the lung scan or effusive blood effusion by the Morrison approach. Or we obtain the chest X-ray. Chest X-ray is normal. There is no complication like pneumothorax or effusive blood. This is a laboratory finding. Everything is unremarkable except VBC, white blood count is slightly rise, 30,000, and creatinine little rise 1.36, and glucose 150, and everything that is okay. So the patient is deposition in cardiothoracic surgery and follow up. See hospital in 6 days. Conservative management. During hospitalization, patient is stable, do not need to surgery. So this is a theory for penetrating chest trauma. Chest trauma is has a quite reason to be second most common traumatic injury. Mortality rate about 60 depending on mechanism injury. Penetrating, in this case, penetrating case trauma is less common than blunt trauma, but it can more deadly. Quick thinking and early intervention are a key factor for evaluation, management, and survival. And etiology is gunshot, stabbing like this patient, impaling injury like fall, collision, blast injury, fragmenting military device. Evaluation routine method of trauma protocol is evaluation, reduce miss injury. Recognition in primary survey, we have to find the life-threatening like large pneumothorax, large pneumothorax, pedicle effusion with or without tamponade, hemoperitoneum depending on trajectory. And reveal in secondary survey, we have to find a refracture, small hemotothorax and small pneumothorax. Small pneumothorax we can find by the lung protocol atau IFAS protocol, even the pulmonary condition and chest wall condition. Diagnosis, chest X-ray, especially in limitation in supine position, we can see a small pneumothorax or pneumothorax may be missed. IFAS could be done along with primary survey. Can quickly identify the air, pneumothorax or blood like hemothorax atau hemoperitoneal. Chest CT may be more sensitive and specific, but require stability to transport. Endoscopy, bronchoscopy, and ECG need evaluation when warranted. Management is same, ABC management, injury-specific intervention like emergency thoracostomy. 50% case require operation management. Surgery should not be delayed. Operative exploration and EDT, emergency department thoracotomy. Admission, asymptomatic with normal imaging, need observed for delay injury, repeat imaging at least 6 hours. Minor injury, close monitoring and pain control. Advanced level monitoring if the patient has 3 or more refracture, flank segment, or any number of refractor with pulmonary condition, pneumothorax, hypoxia, dan pre-existing pulmonary disease. For pain control, we can use opiate, intrapleural nerve block, intracerebral patch, PCA or epidural analgesia. Infection control, we can use antibiotic and update tetanus vaccination for all penetrating injury. Thank you.
Thank you, Dr. Andrew, for this very clear and demonstrations on the use of the ultrasound to diagnose cardiac tamponade and the demonstrations of how the cardiocentesis in severe patients. So is there any questions from our attendants today? You can either to type your questions in the chat box, or you can raise up your hand using the raise up hand sign, and so that I know who is going to ask questions, and then you can turn on your speakers to ask.
Hello. I'm Silver Cam. I should like to ask, what is the outcome of the patient? Did the patient also receive cardiothoracic surgical intervention? What sort of cardiac injury was identified in the operation, and how was it repaired?
Okay. Thank you, Mr. Kam. This patient is private insurance. There is no insurance. She private. She want to operating, but the patient after 6 hours, 6 days, the patient and ultrasound, repeat ultrasound, the effusive pericard is getting more or less. So the surgeon, cardiac surgeon, decide to observe in 6 days, and the patient has a conservative management. Mr. Khan.
And so he, sorry, it was a bit shaky. So he sustained right ventricular injury and was managed conservatively only.
Conservative only. Patient in ECG is normal. Even in ECG normal, we assume that the patient has no injury in the myocard. The ECG is sinusoidal. There is no STEMI elevation in ECG, so the patient is maybe is a minor injury in, or I don't know the source of bleeding, but with conservative and only TCC withdrawal after before and the next day, the result is okay. So the plan before is after we perform TCC, we plan to cardiac surgery to open thoracotomy, but after wait and see 1 and 2 days, the better patient is getting better, so the conservative. So patient is normal too. The myocard is still normal. There is no difference in ECG, Mr. Ken.
I see. Any follow-up echocardiography for the patient?
I have, but I'm not put in my my presentation.
I see. And so the pericardial collection subsided in how many days?
As long I follow this patient, in 3 days, the cardiologist perform ultrasound, echo. The effusive pericard is disappeared, almost normal in 3 days.
I see. Okay. Thank you very much.
Thank you,
Thank
Mr.
you.
Cam.
Thank you both, Dr. Andrews and Dr. Cam. Any other questions from our audience?
Can I ask question, please?
Yes, please go ahead.
Good evening, everyone. I'm Dr. Aulia. Okay, Dr. Andrew, according to your experiences, from which side we can do the pericardial synthesis in the most safest way?
Pardon? Can you repeat?
According to your experiences, in
Sorry,
which side we can do the pericardial synthesis
Oh.
in the very safest way, do in which side, from apical?
Oh yes,
from
yes. Okay. Depend on pericardial perfusion. If acute pericardial tamponade, usually I choose like trauma like this one. I usually use subsequent because the fluid almost always have the posterior area in cardiac, so we better do approach subsequent. But in chronic pericardio or tamponade, usually the fluid is much more, about 2 liter. Above 2 liter, it will make cardiac tamponade. So in chronic, I usually prefer is apical because it's more short from skin to pericard, only about 2 or 3 centimeters and direct to pericard. In subsequent, there is many complicated. Maybe complicated is happen. Like will look you maybe you can puncture the left lobus hepar, stomach. Full stomach, you can puncture the stomach, even the diaphragm. So before you approach subsequent approach, you better to screening around the pericard. Use the curve code. You can see left lobus. There is which part, which lobus. The important thing you have to find the stomach full or empty. If empty or full, better you decompress first. Decompress for purpose so stomach not full, because there is a risk for me to puncture the pericardial synthesis. Pericardial synthesis have to we have to weigh dynamic or static. Better you perform with dynamic approach. You can see around the needle, left lobus, stomach, depend compare then static guiding. That's it, Dr. Aulia. Jadi for acute I choose subsequent. For chronic with large effusive pericard I choose apical or parasternal. The apical is better.
Thank you.
For me.
And unfortunately, in my ED, I don't have linear probe. Is it possible for me to do the pericardial synthesis using the abdominal probe?
Okay. For subsequent, I use curve linear, a curve probe, abdomen probe or curve probe, because the penetration is more deep than the linear. When you choose the apical, because it's very not too deep, and linear probe is better. But from cypsoid is very quite long. You need the deeper penetration, but the deeper penetration we can achieve by two probe passer array or abdomen or curve probe. You can use for subsequent.
Thank you very much.
You're welcome.
Anyone who would like to ask questions? Because we are ahead of the schedule at this moment, and the second speakers will only be available in about 15 minutes later. Once again, thank you, Dr. Andrew, for his presentations, and also we have a very fruitful discussions on those related to cardiac terminals and also busulfanosis. Thank you very much.
You're welcome. So thank you very much.
So is participants, are you ready?
Yes, I'm ready.
Okay. Oh, okay. We can start.
Yeah.
I would like you to start. Okay. But before that, I would like to introduce our guest speakers, who is representing the India to give the talk, and Dr. Patipanda Sotrana is graduated from received a medical degree also in medicine trained. And she is a fellow of the International Society for Healthcare Quality, and also pursuing a PhD in the Lincoln College University. Her main interests will be the crash through involving one of the principal investigators of crash through multi-center studies in the past, and also she has involved in multiple research publications and presentations in various conferences. And she is also the editorial board members of NJEM, and also she is also the members of the research committee of the IFRAM. She has leadership in terms of as a national treasurer of the Society of Emergency Medicine in India, and also the controller of examinations of the Society for Emergency Medicine in India. So today the topic is very interesting. She's going to talk about the gender-specific resuscitation and emergency departments. So without further delay, I would like to please join us to welcome Dr. Shajana.
Yeah, can you see my screen?
Not
Not
yet.
Not yet.
Not yet. Okay.
Please be patient before our guest speaker to join again. She anything encounter some problems in using the Zoom. She is trying to rejoin again. Okay, please be patient. Yes, we can see your screen. I'm sorry that have you turn on the speakers seems that you are late.
Am I clear now?
It's okay now.
Yes. Good afternoon, everyone. Sorry for the technical glitches during my presentation. Today, I will be speaking about gender-specific resuscitation. I am an emergency physician. As an emergency physician, I am trained to treat every patient that walks into the doors of emergency room, be it a stuffy nose, be it in a trauma, be it a chest pain, whatever walks into the doors of emergency room, I treat them. While I treat them, I take history, I order tests, I prescribe medications without ever taking their gender into consideration. Why would I take it into consideration? The traditional medicine assumed men and women are same except for their reproductive organs. For many, many years, women are not included in the research and no differences has been considered with respect to the pathophysiology, symptoms, diagnostic tests, or treatment when it comes to men and women, except for their reproductive organs. So what is the result? 80% of the drugs withdrawn from the market are due to the adverse or side effects that happen on women. Isn't it alarming? So it has been predominant in the human medical research that men has been tested and introduced into the market, and then when they come up with side effects, then they start withdrawing. So why is this happening? They consider that when it comes to human medical research, they need to have informed consent, and men are considered as homogeneous and then not much of differences happen, and with a good intention to protect women of the childbearing age, which they undergo with lot of hormonal changes. So because of all these factors, for many years, human medical research is restricted to test only on men and then introduced to women and children. As a result, we have been taught to assume that men and women are identical except for their reproductive organs. So the most common drug what we use or what we prescribe for treating insomnia is zolpidem. This drug has been withdrawn, or it has been shown to be given at half a dose for women. Otherwise, this drug is meant to stay in the circulation for a very longer period and turns out to be very risky for women who is supposed to get up in the morning and do the daily course and go to work driving long distances. They are prone for more accidents because of this drug. So it has been discovered after releasing into the market that this drug actually has to be given only half the dose. Do I know this for the last 10-15 years of my practice? I would say no. I have been giving the same dose for both men and women until and unless my realization of gender specific emergency medicine has come into place. So this has changed the concept of bikini medicine, which used to be taught only for reproductive group. The reproductive organs, they are different, has been changed to gender specific medicine. So for pediatrics, it is a very common norm for most of us working in the emergency rooms. What is the dose to be given for pediatric patient? Half the dose of the adult is a very common norm that we practice. So, and for men and women, there are no differences that has been taught to us any day. But the concept of gender-specific medicine has come in an interesting way. So I would give the credit to Dr. Marianne Legato, who is a physician and has a researcher from United States. And she was asked by American Heart Association somewhere in 1990s to test what are the differences between the heart diseases of men and women. So she thought, what differences will I find? They are just the blood vessels and heart are going to be the same between men and women. But as her research advanced, she realized that each cell has a sex and each cell has a gender and they behave differently. And we have to consider that when we are treating the patients. So what does gender-specific medicine does? It examines how normal human biology and physiology differ between men and women, and how diagnosis and treatment of disease differs as a function of gender. So this is what the gender-specific medicine per se talks. So 2014 is the year of realization for emergency medicine, again in the US. So they have done a consensus conference to see or identify gender-specific care as an area of importance in emergency medicine as well, because we deal with a lot of life and death situations, and we should be aware what are the differences that need to be considered. So sex and gender-specific emergency medicine has taken place, and it is divided into, again, women's reproductive health and men's reproductive health, and that diseases associated with that has been considered. And sex and gender-based medicine has taken a big role, which includes the way we resuscitate patients, the way the drug metabolism and metabolic diseases behave between men and women, and how the differences of cardiovascular diseases and skeletal injuries occur. So if we have to speak about gender-specific emergency medicine, it is beyond the scope of this lecture, but I will try to summarize most important and most commonly encountered problems of the emergency room and with respect to the resuscitation. So these are the few things I'll be going to speak on, how the gender differences matter when we deal with cases like acute coronary syndromes, ischemic or strokes, trauma and septic shock, again another emergencies we commonly look at, and what are the differences that we have to consider when we are intubating a patient in the emergency room, endotracheal intubations, what differences has to be taken. Procedural sedations, again another most common thing that we face in the emergency room, and what differences has to be managed, and how cardiac arrest management has to be differentiated for both men and women. So it has been common norm that heart attacks are more common in men than women, and there has been a myth, I would say this as directly as a myth, that women of reproductive age group are protected from heart diseases. What is the literature saying? It is not that they are protected from heart diseases. We are underdiagnosing them and undertreating them, because the symptomatology of heart diseases in women is different from that of men. So the most common findings, what we find in men, are crushing chest pains, cold and profuse sweatings commonly associated, or pain radiating to the neck or left arm. And these symptoms are sudden in onset. So the way we describe a typical chest pain is also containing only these factors. But what are the symptoms that we find in women? They can have profuse sense of fatigue, shortness of breath. Most common finding of acute coronary syndrome in women is shortness of breath. Or they can have a flu-like discomfort. They may come with body pains, or not feeling good, or fatigue, or feeling of indigestion or heartburns. Most common again is this. And these symptoms does not come all of a sudden, just like in men. They continue for very, very long days, maybe weeks as well. So because of the nature of the symptoms, we have been underdiagnosing women. So again, there is a bias in treating women. What is the bias? We usually don't treat women aggressively than men, and they don't undergo stresses as frequent as men. The reason could be because they're not able to walk on the treadmill, or they have knee pains. Because of all these factors, we don't put them to the stress test, and very few undergo angiography and revascularization. So because of these biases, we treat women less aggressively. So this is a scientific statement which says acute myocardial infarction in women, that they realize that right from symptomatology, pathophysiology, even the diagnostic tests are different between men and women. So when come to the risk factors between men and women, men, the most common risk factors we all know, it could be hypertension or dyslipidemia. But when it comes to women, it can be type 2 diabetes. The most common risk factor for women is diabetes. And for diabetes, we already know they can have silent MIs because their presentation of chest pain is different, both in men and women. And in women, it aggravates that we miss the diagnosis of chest pain in women. Smoking, metabolic syndrome are the other risk factors. And women that go through depression and autoimmune diseases are at more risk for cardiovascular diseases. And pregnancy-related complications like eclampsia, pregnancy-induced diabetes, or pregnancy-induced hypertension again make the woman more prone for heart diseases. Coming to the pathophysiology, we all know there is an ACS because of a plaque rupture which causes ST elevation. This is the typical STEMI definition we call it as. But women, the pathophysiology is different. They can have endovascular dysfunction or erosion. They can have just coronary artery dissection or a spasm, which makes either can have a ST elevation or non-ST elevation, or they can have Takotsubo cardiomyopathy like symptoms. Coming to the most commonly used diagnostic test for ACS is troponin assay. What is happening with troponin assay between men and women? The 99th percentile serum levels are consistently lower in women than in men. So what happens because of that? Most women with acute coronary syndrome will have normal troponin levels, and just because their pathophysiology may not be ST elevation MI, because of spasms or whatever I have said, we may not find typical ECG findings in women. The next thing what we do is troponin. The troponin levels will be consistently lower in women. So it becomes a diagnostic challenge for ER physicians to diagnose ACS in women. We may rule it out. First, they don't have a typical chest pain. Second, they don't have a typical ECG. Three, they don't have a elevated troponin. So which makes us to rule out chest pain in these cases, rule out ACS in women, and we don't treat them aggressively thereafter. So we have to adjust diagnostic threshold to sex-specific standards, which makes us to improve the precision in ACS diagnosis in women. So this is the paper that talks about gender differences of cardiac troponin. So the peak tropi levels are 4-fold lower in women than in men. And this is the reason why women go for PCI with a lesser rate than men. So alert for ER physicians, no bias for normal tropi levels in females. If you find a normal tropi level in a female who is having ECG changes not consistent with ST elevation MI and symptoms not consistent with typical symptoms what the textbooks have taught, despite this, we have to make them go through a angiogram at least to find out what is happening in these patients. So it gives us an opportunity for aggressive screening. A knowledge of gender-specific medicine is very, very important. And even if angiogram is normal, there are other diagnostic modalities like functional CAGs can be done, which will help in diagnosing if it is only a vascular spasms that are happening in these people. And another thing, periodic health checks has to be mandated. And we have to set this tone from the beginning of the evaluation. Again, convincing a woman for admission is again a difficulty. In my country, very, very difficult. I'm sure it will be with the same way across the world, that women tend to give more priority to take care of the family or child who is left at home rather than taking care of their health. So we have to set the tone from the beginning of the evaluation itself, that there can be differences what we encounter. Then coming to stroke, acute stroke, again, there are a lot of differences between men and women. This is the paper that says. So right from the symptomatology to presentation and treatment as well, there should be awareness and education of gender differences are needed. And prompt recognition of stroke is very, very important to avoid major catastrophes in their life, which causes morbidity and mortality. Coming to sepsis, trauma and shock, another most commonly encountered emergencies in the emergency departments. Again, there are a lot of differences that are seen. So for trauma and sepsis, there has been a trial that has been happening by giving, it is noted that estrous cycle is beneficial for women of premenopausal age. So when there is 17 beta estradiol levels are more, it gives protection to the end organs like brain, kidney, etc. So there has been trials that have been happening by giving 17 beta estradiol to protect these patients from end organ failures when they encounter most emergencies like trauma and shock. So 17 beta estradiol administration following trauma and hemorrhage decreases organ damage by decreasing inflammation and decreasing the levels of interleukin-6 levels, and also improves the function and vascular responsiveness of the vasoconstrictors we use, and reduce pro-inflammatory cytokines, and reduces and decreases renal injury as well, and neutrophil interactions can be attenuated. So there are a lot of benefits that has been studied by giving 17 beta estradiol for patients of trauma, shock, and sepsis. Coming to the effect of drugs, of what happens when we administer drugs between men and women, very, very important. So there are differences that has been noted between men and women. I don't know how many of you come across, the most commonly used drug is propofol in the emergency rooms. And if you give propofol of the same dose to a man of 100 kg versus a woman of 100 kg, women comes out of the sedation faster than men. So they need more dose. I don't know how many of you experienced it. There is a science behind it, why it happens as well. So females require lesser dose of water-soluble drugs and more dose of fat-soluble drugs. So if you give rocuronium, midazolam, etc., you need to give 30% lesser dose for women. And when you give lipid-soluble drugs like propofol, you need to give more dose for women. So an interesting finding during my post-graduation days, all this I start recollecting after having awareness of gender-specific medicine, that if I give 6 milligrams of midazolam for sedation to a female, they go in for respiratory depression, but men tolerate it better. So I used to have this doubt in my mind, why is this happening? So there used to be an interesting argument that, maybe the man you gave is an alcoholic and he can consume a lot of midazolam, and not the same case with females, but that's not the fact. Any water-soluble drug, because of body consumption, body composition, females require 30% lesser dose than men. So this is what I have been saying. When you give propofol of the same dose, women wake up faster from their sedation. So due to variations in body size, composition, drug metabolism, clearance and hormonal effects, there is changes that happen between men and women, and not just limited to reproductive age group. So drug pharmacokinetics and dynamics also vary between both sexes. So lipophilic drugs, because of a higher percentage of body fat, they should receive higher doses. Women should receive higher doses. So large volume of distribution and lower plasma concentration. So the drugs like propofol, the dose required for women is more than that of men. Hydrophilic drugs, they should receive lesser dose because they reach higher plasma concentrations and they stay in the system for a longer duration. So when you are giving drugs like rocuronium or midazolam, we should reduce the dose for a woman than for a man. Then the most important, there has been an interesting study among us that if you are extubating a patient out of a mechanical ventilation, invariably females will have sore throat or change of voice, and it will be more concerning for us while we extubate them. So there is a science behind that as well. Soreness, sore throats and hoarseness of voices are more common in women after endotracheal or laryngeal mask airway insertions. So LMA carries more higher risk than endotracheal intubation for sore throat, and incidence of hoarseness of voice increases in women if the intubation stayed for more than 24 hours. Then coming to cardiac arrest in women. So do we treat cardiac arrest the same between men and women? Yes, but there are differences even before they reach the hospital. They are less likely to be resuscitated. Women receive less pre-hospital care than men, and they come up with non-shockable rhythms are more common in women, which makes them difficult to survive after resuscitation as well. And by the time women get into a cardiac arrest, they are 3 to 4 times older than men and less likely to have a witnessed arrest. By the time women experience a cardiac arrest, they might be either staying alone or there is no bystander by them, which will help in resuscitation. And again, they can have less aggressive care. So bystander BLS and early defibrillation is noted to be less in women than in men. And very soon, a woman is withdrawn from care, resuscitative care, than in men. And women are underrepresented in our randomized control trials, so we don't have an exact data. So CPR training, most of us use the same mannequin, and sometimes for a general population, there is a hesitancy of initiating CPR in women. So there is a need for mannequins which will imitate the chest and make them train to give CPR, might help in receiving a better pre-hospital care in women as well. So what does this evidence teach us? What I have been talking is only just tip of the iceberg. There is so much to learn about women's health and women gender-specific medicine, not only in emergency medicine, but every specialty should be aware of this gender-specific medicine. So can we utilize is men and women as the same for clinical practice? The evidence says no. So this information or knowledge should be a game changer for your clinical practice and should make you aware that every time we see a female in the emergency medicine, we should question ourselves, am I doing the right thing for this patient? So how can we improve this gender-specific medicine across all the specialties? We should have clinicians who does the practice of gender-specific medicine. We need to have researchers who does aggressive research on women to give us more information and more updates, and medical educators who should train the medical graduates about gender-specific medicine. So gender-specific emergency medicine is a conglomerate knowledge between doctors, nurses, students, and patients. We should educate the patients as well. And next time a patient should be able to ask, are you giving me gender-specific medicine or not? So change does not roll on in the wheels of inevitability, but also through continuous struggle. And this should continue till we reach the gender-specific emergency medicine as a specialty itself. So it happens by change, creating awareness, and an opportunity to learn and practice. It is not just for women's health, it should be a personalized individual care for everyone. So femtech is something that is coming up as a future for women's health, is a promising thing that is helping many women who are in the remote areas to access medical care. So it addresses gender gaps by innovating new concepts and integrating existing medicine and gender-specific medicine knowledge and creating an impact. So what are the advantages we can have by taking technology in women's health? It can improve care delivery, improve the diagnosis, and we can deliver a tailored care or individualized care and address stigmatized areas of care and enable self-care for women as well. So when we look at women's health and needs, we just can't help but learn about men's health too. By understanding women's health, it helps men as well. So we tried to make a difference by trying to get gender-specific emergency medicine guidelines soon. I'm happy to take some questions.
Thank you very much for Dr. Sundrana for her presentations on the gender-specific resuscitations. Well, will there be any questions from our audience? You can, just like the previous presentation, either you type in the chat box or you can raise up your hand to ask questions.
Hello, Senator Cam again. I should like to ask concerning the resuscitation drug. Any major differences between men and women? For example, adrenaline, atropine, amiodarone, that we need to adjust the dosage? Thank you.
Yes. So coming to adrenaline and amiodarone, there is not much of a research yet, or we don't have RCT trials. But as per the literature, if it is water soluble, we have to give 30% lesser dose for women. And if it is lipid soluble, we have to give more dose so that the peak levels are reached. So there's still the research is going on that part. So we don't have any evidence to say that we have to give lesser dose or more dose.
Okay, just the general principle and nothing specific yet. Thank you.
Nothing specific yet, yes. There's a lot of research yet to go.
Thanks indeed.
Thanks, Dr. Kim again. Well, any other questions from the floor? Okay, seems everybody are very satisfied and also feel very fulfilled for the presentations by Dr. Sundrana. So once again, thank you very much for your presentations and your sharing about the gender-specific problems related to resuscitations. Thank you very much. So we are much earlier than the schedule today. So Gordon is here. So we can go to the final part of the OSCE. The OSCE is presented by our Hong Kong colleagues, Dr. Gordon Wu. So I'll pass the okay first. Okay, please start.
Hello, can you see my slides now?
Yes.
Okay, all right. Just a second. Just a second. Sorry. All right, can you see my slides now? Yeah.
Yes.
Yes, okay. So good evening, my fellow colleagues. And I'm Dr. Gordon Wu from Hong Kong. And currently I'm working as a pre-fellow in the Department of Accident and Emergency Tin Shui Hospital in Hong Kong. And today I'm glad to be one of the representatives for our society, which is Hong Kong Society for Emergency Medicine and Surgery, to share you a few cases. So here comes the first case. So we have a 73-year-old lady. She was sent to a rural hospital. That is my hospital, Tin Shui Hospital in Hong Kong. She has no lung drug allergy and non-smoker. Previous history, she has a known history of some cardiac conduction disease and also affected liver. Presented to us with palpitations for 2 days with some shortness of breath and bilateral lower limb swelling. She has no fever. She complained of low chest pain and there's no loss of consciousness. Upon the physical examination, the chest is clear, the heart sound was still, no murmur. The abdomen was soft and non-tender on palpation. There was a mild bilateral lower limb edema. So the vitals are stable, but she has a tachycardia or pulse of 151 beats per minute with a good saturation, and she was febrile. And this is the ECG in the resuscitation room. Okay, we looked in the computer system, and this is the previous baseline ECG for this patient. So this is the chest X-ray in the resuscitation room. This is a chest X-ray at AP frame and sitting position. So here comes the first question. What is your provision diagnosis for this patient? So we have several options like paroxysmal AF, SVT, pre-excitation AF, and also an atrial flutter with variable block.
Okay, you can try to answer by a poll for the false answer. Choose your. I'll give about 10 seconds for you to choose, and then I'll close the poll, and the result will be displayed. Okay, so time's up.
Okay, seems most of colleagues choose PAF and also pre-excitation AF as best two options. Okay, so do I need to show the share results?
Yeah, this is.
Okay, this is the result. Okay, so here comes the second question. So what is your initial management for these patients? So we have IV adenosine, amiodarone, CCB, which is a diltiazem, digoxin, some beta blockers, procainamide, and also directly strict to go for the synchronized cardioversion.
This is up to 8 options for you to choose.
Also, a keep observation is also one of the management. Yeah.
Okay, please cast your votes. Okay, time's up.
Okay, so seems most of us choose amiodarone as the first choice, and secondly as digoxin. Okay. Okay, so the provisional diagnosis for this patient is actually a pre-excitatory AF with a history of Wood-Panson-White syndrome, and also she's in some mild heart failure. As you can see from previous chest X-ray, it's a bit congested with cardiomegaly. And also, we perform a focus echo. The EF is fair, and also it shows a bilateral lung increase in B lines, and the IVC is engorged. Actually, she has the past history of Wood-Panson-White syndrome, and is right-sided right posterior septal pathway, and she has an EPS done in 2007. There's no inducible SVT and no RFA was done. Also, she has a King of Heart study, which is kind of a long-term ECG monitoring, and she did have some patient events. It's all in sinus rhythm with delta wave only. So this is the baseline ECG. The left-hand side one is the baseline ECG. You can see it was in sinus rhythm with marginally short PR interval is 120. The cutoff usually is lower than 120. And I also have a widened QRS interval. And as you can see in V1 lead, there's also a slurring wave, so what we call delta wave, and also have a dominant S wave in V1. So it signifies it's a right-sided accessory pathway, and it is as known as a type B Wolfram-White syndrome. This is on the right-hand side, this is a magnified version of ECG in a resuscitation room. And you can see she's in AF with 150 beats per minute, and also shows there's a delta wave rather than QRS interval. So for our management, we decided to go for the cardio version, and as a patient is in AF with mild heart failure, and also we also think of another option that is IV procainamide. And however, I call my on-call pharmacist in Tin Shui Hospital, as we are in a rural hospital. Actually, there's no procainamide available in my hospital. So I decided to perform a synchronized cardio version under procedural sedation and analgesia after discussion with an on-call CCU doctor in another hospital. So firstly, we attempt at the 120 joule, and then we attempt 150 joule. After the cardio version, she is still in AF, but with a slower heartbeat of around 106 to 113 beats per minute. Since the patient is stable now, so we decided to transfer to Port Oil Hospital, the coronary cardiac unit, which is a hospital adjacent to our rural hospital. So after admission, the serial troponin I suggests no ACS, and she was with a bit hypokalemia, and she was given a K supplement, and otherwise the blood results were all unremarkable. She was also given with some Lasix and also a procainamide infusion, and afterwards the rhythm converted to sinus. So the rhythm, the ECG after the cardio version is in sinus rhythm with some first-degree heart block with TVA inversion over inferior and also anterolateral leads, and with a prolonged QTC interval. The cardiologist also performed an echo for her, and shows a good EF with 55%, and also with a preserved RV function. Later on, EPS and also the radio frequency ablation was done, and it shows there's an accessory pathway at the right posterior septal position, and a successful ablation of the right AP was given to this patient. As she was also in AF, a participant was also initiated according to the protocol. So this is the second case. We have a 60-year-old gentleman also sent to Tin Shui Hospital for palpitation. He was with a long history of Wolfram-White syndrome with palpitation, but he declined EPS and also RFA. The surface ECG shows an intermittent delta wave, and the Holter study also showed the diagnosis was Wolfram-White syndrome. He was previously recurrent admitted for palpitations, but all episodes of palpitations returned to sinus rhythm spontaneously. And today, he presented to us with palpitations for a few hours, and there was no fever, no chest pain or shortness of breath, no LOC, and no lower limb swelling. And on the ambulance, the cardiac monitoring shows the heart rate of around 210 beats per minute. And he was stable in our resuscitation room. The BP pulse was stable with tachycardia, shows 208 beats per minute, and he was afebrile with a good oxygen saturation and not in respiratory distress. So this is the first ECG performed in a resuscitation room. So we performed a modified Valsalva maneuver for 2 times, but we failed to abort the arrhythmia. So this is the schematic diagram showing how the modified Valsalva maneuver was performed. And we need to put the patient in a sit upright position of 45 degrees, and ask the patient to blow against the syringe. Since usually we use a 10 ml syringe. And after that, we lie the patient flat, and also to raise up his legs, and then to put a patient back to the sitting position. So this is the third question. Well, what is your next step of management for this patient? So we have several choices. We may attempt other vagal maneuver, consult cardiologists to do a synchronized cardio version, to give IV adenosine, abiraterone, or diltiazem. Be reminded that this patient had history of Wolff-Parkinson-White syndrome.
Please make your choice for the answer. Okay, time's up.
Okay, so you can see the result. The best two options are IV adenosine and also synchronized cardioversion. Okay, so we give the patient IV adenosine, push bolus dose, and it convert to sinus rhythm. This is the post cardioversion ECG. So for other investigations, the chest X-ray was clear, and the routine blood results were all unremarkable. He was then admitted to medical ward, and the patient was keen to proceed with EPS, and outpatient appointment for EPS was arranged and discharged. So let's talk about Wolff-Parkinson-White syndrome. So it's a presence of a congenital accessory pathway, an episode of tachyarrhythmias. So it's also as known as a pre-excitation syndrome. There are mainly two forms of tachyarrhythmia, which is AVRT, the atrioventricular reentry tachycardia, and also the AF in pre-excitation. So I usually describe to my patient for Wolff-Parkinson-White syndrome, also the patient presented to our resuscitation room when they have a tachycardia. It's kind of like a short circuit scenario. So for the baseline ECG and also what we call a surface ECG, what are the features for Wolff-Parkinson-White syndrome? Usually the PR interval is short, is shorter than 120 milliseconds. And also there's a presence of delta wave with a slurring, slow rise of the initial portion of the QRS, and also if a widened QRS. And it also have some ST and segment T wave inversion, like ST segment and T wave changes, which is a disconcordant, as shown here at the right-hand side schematic diagram. So there are mainly two forms of the tachyarrhythmia, and which is pre-excitation, and also for the AVRT, it can also divide it into orthodromic type and also the antidromic type. It depends on the direction of the current conduction. So orthodromic is clockwise, and antidromic is anti-clockwise. Okay, so usually this is more common. You know, AVRT group orthodromic type is more common than antidromic type. Usually it presents as, for the middle one, it usually presents as a SVT. And for the pre-excitation one, this is presented as a pre-excitation AF. So also there are two types of Wolff-Parkinson-White syndrome, and if there's a presence of an AP over left side, it will produce a positive delta wave in all precordial leads with R over S ratio of greater than 1 in V1, what we call a type A Wolff-Parkinson-White pattern. So we have a positive R wave here. And in V1 and V2, if we have a negative R wave in V1 and V2, then also a negative delta wave in V1 and V2, it is called a type B Wolff-Parkinson-White pattern, which is signifies there is a presence of right side AP. For the features of pre-excitation, it may be sublow or present only intermittently in the surface ECG, and it can be magnified if there is an increase in vagal tone, like doing a Valsalva maneuver, or we give the patient some AV blockade drug. So for the management of AF with pre-excitation, this is the ECG in our first case, and she was in pre-excitation AF. So as we can see, we have a short PR interval and also widened QRS. QRS and also presence of delta wave with irregular rhythm. So this is a case of pre-excitation AF. So for the pathophysiology of pre-excitation AF, usually we have two conduction pathway, namely the AP, this is the AP, the accessory pathway, and also we have usually the normal pathway, which is a AV node. Usually the refractory time of AP is much shorter than the refractory time of AV node. So both AP and also AV node can do the anti-gray conduction. So and also for the AVN conduction through the middle part here, it can also block the AP conduction. So it causes the rhythm of AF or imprecitation. So what if we give an AV nodal blocker? We block the AVN, then the rapid conduction of AP will from the atrial to the ventricle and may cause VT. So it can be catastrophic. So firstly, do not give a patient any AV nodal blocker. So for my mnemonics used is ABCD for AV nodal blocker, which is adenosine, beta blocker, CCB, also digoxin. For the patient with unstable hemodynamic, we may strictly go for a synchronized cardioversion. And also we may consider IV procainamide in this case as patient is stable. For IV procainamide, it is a class 1 antiarrhythmic that targets the AP. And also it have a prolonged action potential duration in atrial and also the ventricular myocardium level. And he has no, the drug has no AV nodal blocking effect. And the drug is effective in both reversion and also in slowing the ventricular rate. And it is also safe in children. And it is given in bolus followed by infusion. However, if the patient has a severe heart failure or prolonged QTc interval, then you may try to avoid this drug. And this is our second case, which shows SVT of heart rate around 200 beats per minute. And it is a more common presentation of patient in Wolfram-White syndrome, and also presented with AVRT. So it is also equal to the orthodromic AVRT. So the ECG features also usually presents with a heart rate of around 200 or 300 beats per minute, and the retrograde P waves are usually visible with a long RP interval. And usually the QRS is short unless a pre-existing bundle branch block or rate-related branch conduction. So we usually see it's a SVT with a short QRS interval. So mainly we can firstly, we can do a DC cardioversion if you are in doubt, and it aims at slow down the AV node conduction. And the management is actually similar to the management in AV-NRT, and we may also attempt some vagal maneuver and followed by adenosine or verapamil. So the nodal blocker like adenosine or CCB is not contraindicated in this case. For the management of antidromic AVRT is a bit complicated. Firstly, it's a very rare presentation of a patient with Wolfram-White syndrome presented with tachyarrhythmia. It's only around quoted as 5% only. There is an anti-gray conduction via the AP pathway, and the AV node will do the retrograde conduction. So this abnormal direction of ventricular depolarization may result in a broad complex tachycardia, which is similar to VT. The rate is usually 200 to 300 beats per minute, and it has a wide QRS complex due to the abnormal ventricular depolarization while AP with anti-clockwise direction. So the ECG represents as a VT-like pattern. It is technically difficult to distinguish from VT if you don't have any history of Wolfram-White disease long. The management is similar to VT. And if you're in doubt, and we can give the first line procainamide or second line the ibitidine, or if you're in doubt, just strictly go for synchronized cardioversion. So actually, this is the ACLS algorithm in 2020. So for the first case, the patient was in AF with Wolfram-White. So she had some signs of acute heart failure. And so we follow this protocol. Firstly, we may consider synchronized cardioversion. And if refractory, then we may also consider procainamide administration with the dosage as quoted here. And also we can consult our CCU colleague as well. For a second case, a patient with a history of Wolfram White presented with SVT. So a patient was stable and the QRS was not widened. So we follow the pathway and we can actually give some vagal maneuver and also to give adenosine as the rhythm was regular. Okay, so this finished the topic of Wolfram White disease. Okay, so here comes the third case. We have a 79-year-old gentleman enjoy good past health, and he was noted to a sudden collapse at venous spinal labor, and he recovered spontaneously. The first set of BP and pulse was undetectable on ambulance, but he soon recovered with SBP around 90 millimeter mercury. He complained of low fever, no chest pain, no back pain, and there was no unilateral limb weakness or numbness, and he has no head injury. The vitals are shown here with a borderline BP of around 98/76 millimeter mercury with a pulse of around 110, and he was afebrile, and also he requires of some oxygen supplement, 2 liters of oxygen via the nasal cannula, but the saturation was satisfactory. Upon the physical examination, the GCS was full with a clear chest, and also the power over limbs were all full. So this is the ECG of this patient, and it is an sinus rhythm with some very subtle ST depression over the lead 2, and also the ABF. And this is the X-ray of this patient, chest X-ray. A reminder that this is a supine frame in resuscitation room. Okay, in view of the ECG change, I perform a focus echo for this patient. This is a subcephaloid view. Okay. So what is your impression of this patient? We have acute PE, silent MI with free wall rupture, malignant pericardial effusion, and also aortic dissection of this patient.
Okay. Any more? Okay, we'll stop here.
So let me share the results. Okay, so the top choice was silent MI with pleural rupture, followed by aortic dissection, also PE. Okay. Okay, so we perform a CT aortogram for this patient. So we look at the plain film first. Okay. Okay, the right hand side was the contrast one. Okay, the CT reports revealed there was a type A aortic dissection in this patient involving the aortic root and also ascending aorta with hemopericardium. And also there was a thoracic aortic aneurysm at mid to distal aortic arch. And also there's incidental findings of AAA. So the patient now presents with a borderline BP of around SBP around 80 to 90, okay, with a bit tachycardic. What could you do for this patient? Remember, he is with a type A dissection with hemopericardium. So we may do the polling now.
Okay, any more want to answer? Okay, we'll stop here.
Okay, so most of us will choose fluid bolus, and also maybe some may consider pericardial centesis. Okay, let's look at the focus echo once again. So he was a hemopericardium here, but the RV, this is the RV, seems not in collapse, not in a diastolic collapse. So we give the fluid bolus first, and he was responsive to fluid challenge. We consult the tertiary hospital with CTS support, and the on-call cardiothoracic surgeon agreed to take over. And bedside echo was performed by receiving team, and it shows a fair EF with basal anteroseptal and also inferior hypokinesia, and there's mild aortic regurgitation, and also reveal a 1.5 cm pericardial effusion anterior to RF. There was no sign of tamponade at the moment, and but it is suspicious of a hemopericardium. The IVC was collapsed. So an emergency operation was done on him with a hemiaortic arch replacement, and he survived and discharged. So this is another question. If the blood pressure further drops to SPP 60 millimeter mercury, we should perform pericardial centesis for him.
Okay. This time the answer is skewed to one side.
So most of us will choose to do pericardial centesis for him. Okay, so firstly, we should confirm the diagnosis of cardiac tamponade by clinical status and also echocardiogram. If the patient is in really critical cardiac tamponade, we may consider to perform a controlled pericardial drainage for this patient to relieve the tamponade. So what is a controlled pericardial drainage? Back to the days of around 190, and back to the days of 90s, it was contraindicated in acute aortic dissection in the past, and there was possibility that rapid and aggressive drainage of the pericardial blood may precipitate a worsening leak from the aorta to the into the pericardium. And there was a study in 1984. It shows quite a bad result, and 6 patients presented with aortic dissection type A with tamponade, and 4 of them underwent pericardial centesis. 3 of them died, 3 of them dead, and also 1 survived, and the remaining 2 patients who did not undergo pericardial centesis survived. However, in 2010, they revised the guideline, so the pericardial centesis can be performed by withdrawing just enough fluid to restore perfusion in a patient with hemopericardium, and also the tamponade, which cannot survive until surgery. So controlled pericardial drainage can actually provide a better outcome when compared to the study back to 1994. And the indication should be a critical cardiac tamponade, which is hypotension after intravenous fluid resuscitation, and with an average systolic blood pressure of around, before drainage of around 60. And the features of the CPD is only a small volume of aspirin was done each time, and it was finely titrated. And the total amount of the blood aspirate is only maybe 10 to 30 ml. And it shows elevation of systolic blood pressure of around 30 millimeter mercury, and the post-procedural SBPs for average is around 95 millimeter mercury only. So in 2015, they revised the guidelines again. So for the pericardial synthesis, it can be performed in a controlled pericardial drainage fashion with a very small amount of aspirate each time to stabilize the patient, and it should be titrate the blood pressure to around 90 millimeter mercury. So this is from a Japanese study. So they well defined what should be included, or what is the way to perform a controlled pericardial drainage. So they use a 8-French pigtail drainage catheter with multiple side holes under LA and also ultrasound gradients. They aim at the thickest point of the pericardial effusion, which usually is at the mid-clavicular line and also the 4th to 5th intercostal space. And they performed a controlled drainage with 5 to 10 ml aspirate each time, and they aim at an SBP of 80 to 90 millimeter mercury. So this is the schematic diagram. What is the point of insertion of the needle, and also what is what we can see if we perform ultrasound directly over the 4th to 5th intercostal space at the left side. So other than CPD, if the patient has an acute accumulation of the hemopericardium from the rupture of the 4th lumen of the dissection, CPD may not improve the circulation as the tube is too small in caliper. So we should perform a CPR and also open pericardial drainage from a subsequent approach if there's a persistent PEA. So this is a schematic diagram of how to do a subsequent pericardiotomy and also pericardiocentesis, but today we won't include how it is done. So this is a case of a painless aortic dissection. So we usually think that aortic dissection should be presented with some short pain, stepping pain, chest pain radiated to back, or some pulse deficit, or some focal neurology. And actually, aortic dissection is missed in up to 38% of patients on initial assessment, and up to 28% of the patient, the diagnosis was made in post-mortem autopsy. The classical findings of aortic dissection could be sudden tearing pain, chest pain, radiated to back, or abdominal pain. But however, it can be also absent. And also they may also present with some focal neurology, like a paraplegia or some signs of acute limb ischemia and hemiplegia. And the classical pattern of the pain is presenting symptoms in over 90% of patients, but however, 10% of them may present with some atypical symptoms. Around 10% of the aortic dissection are painless, and it may present with symptoms secondary to complication of the dissection. So there is a study with 235 patients included, and it reports that 33% of the patients denied pain or discomfort on presentation, just like our patients. So this is a typical presentation I can find on the internet, and I believe there are much more. It includes a syncope, and dyspnea secondary to the acute aortic valve regurgitation, just like our case, the patient present with some syncope only. May also be present with facial swelling, mimicking SVCO. Also may be present with coma, stroke TIA, some coagulopathy, GI bleeding, pericarditis-like picture with some generalized ST elevation in the ECG, and also maybe some pleuritic pain, and a small amount of pericardial effusion. And also it may present as some focal neurology, like inability to walk, bilateral lower limb weakness, progressive motor and sensory deficit, some hoarseness of voice. It may also present as a multi-organ failure if the dissection involved other organs like the mesenteric artery or renal artery that may cause a severe acidosis and multi-organ failure. And it may also present if there's an unexplained non-traumatic left side hemorrhagic pleural effusion, then we must look for any possibility of aortic dissection. So So I think aortic dissection is also one of the great mimicker, like what we have like HIV or TB or syphilis. So we bear in mind that it also be one of the great mimickers. So this is our last case. And this is a 67-year-old gentleman with a previous history of gout and also hypertension. And he presented with left hand dorsal swelling and with some redness for 3 days. He has no fever, no injury, and he has no history of insect bite or no marine contact. For his vitals were stable and afebrile. This is a clinical photo I've taken. So clinically, you can see there's swelling over the left with the dorsal side of the left wrist. And upon pressure, it seems the fractures can be flattened and indentable. And you can also see there is a gross swelling over the left-hand dorsum as well with erythema. So this is an ultrasound performed directly over the swelling. This is the axial view with color Doppler mode on. And this is a longitudinal view, also with a color Doppler mode on. So you may have a look first. So what is your diagnosis for this patient? So we have several choice: cellulitis, infected ganglion, skin abscess, and also extensor tenosynovitis.
Any more want to participate? Okay, so we can close the poll here.
Okay, so the top choice is infected ganglion cysts, and also the second one could be an extensor tenosynovitis. Sorry. So actually, I think this is a case of extensor tenosynovitis. As you can see in the axial view, there is a heterogeneous hypoechoic fluid collection surrounding the extensor tendons. This is the cross-section of the extensor tendons. And this is a retiniculum. So you can see some effusion here and also some mixed echogenicity. And also with the color Doppler mode on, it shows a hypervascularity, so signifies there's some inflammation. For longitudinal view, this is the tendon. You can see it's quite like fibrous and longitudinal. And there's an anechoic fluid within the tenosynovium. And you can see also some mild mixed hyperechogenicity here. And the effusion surrounds the extensor tendon. And also upon the color Doppler also shows a hypervascularity. So extensor tenosynovitis is less commonly described than the flexor tenosynovitis we are known of, like typical signs of like fusiform, swelling of finger, fixed flexion, and unable to extend. Also, the tenderness along the flexor tendon. So for the etiology of infective tenosynovitis, usually is a trauma-related with direct inoculation of the bacteria, or maybe hematologic spread or continuous spread from adjacent tissues. For the treatment of infective extensor tenosynovitis, it mainly consists of analgesic and also IV antibiotics coverage. The common skin flora we aim at is the staph and strep. And for the reason an operation or a drainage is not indicated in a case of extensor tenosynovitis, which is not the case in the flexor tenosynovitis. Is that for the extensor tendons, it's usually lack of a reticular system, and infections tend to be less loculated. So for this case, the X-ray of the lab shows no osteomyelitic change and also gas pockets. And he was admitted to orthopedic ward. The orthopedic surgeon did the aspiration and has used 2 ml of blasting fluid only, and there was no pus. And he was treated as cellulitis with analgesia and IV augmentin, and he was soon discharged. So these are all 4 cases that I would like to share with you all. So for the take-home message, we should know different presentation and treatments of the tachyarrhythmia in patients with Wolfram syndrome well. And also we should stay alert for atypical presentation of aortic dissection. And also we have some rare cases like extended synovitis, or if in doubt, if you want to differentiate from like infected ganglion cysts or like NAF cellulitis, then you may do a focus echo. For the infected ganglion cysts, it should be more rounded and well circumscribed, but in this case, we can't see any well circumscribed structure here. And maybe for cellulitis, we usually see cobblestone appearance only, but not the effusion. So we should do a focus echo to differentiate the way of management, and also like if you can give an oral augmentin, or better you admit the patient for IV management. So thank you all for your attention, and any questions are welcome.
Thank you, Gordon, for his presentation and give us very useful tips for us to survive in the emergency department. So is there any questions from the audience who would like to ask Gordon about these 4 cases? So it seems that everyone's very happy about the presentation today. So before we end the presentations, the academic meeting today, for those from Hong Kong, both the Hong Kong ASEM fellows and trainees will post up the QR code for you to scan to capture your attendance. And for those who would like to ask for the electronic certificate of attendance, please send the emails to ASEM. I'll insert the email in the chat box again. So once again, thank you very much for you to attend the academic meeting today, and we will see you all in November, 24th of November this year for the next academic meeting. Thank you very much.